Let's start with Women's Health Review with pregnancy disorders. I'm going to go a little bit over gestational diabetes, multiple pregnancies, and hypertension during pregnancy, specifically preeclampsia, eclampsia, and HELLP syndrome. Carbohydrates and insulin resistance during pregnancy has a different pattern if the woman is during the first trimester, the second, or the third. So usually understanding that insulin response during the first trimester is normal. It's maintained between 6 to 12 weeks of gestation. Glucose concentrations can even be lower by the end of the first trimester. We can recognize an increase in blood glucose following carbohydrate load is going to be less. So first trimester can be a little bit characterized by hypoglycemia and not hyperglycemia. During the first trimester, serum adiponectin, it's going to enhance the sensitivity of the insulin and it will stimulate the glucose uptake during this early pregnancy, and that's why during the first trimester we don't have problems with hyperglycemia. So insulin response, levels of insulin are normal, but we have enhanced insulin sensitivity due to the presence of adiponectin. Second trimester, we're going to start the development a little bit of resistance to the insulin, and this will be progressive, and we're going to be seeing elevation of glucose concentrations, especially on those pre-diabetes or, of course, diabetic patients. And in those patients that do not have any genetic background. In the third trimester, we will see insulin resistant, possible because we have an increment of levels of cortisol. But the main reason that I want you to remember is that during the third trimester, placenta is already formed, and the placenta is going to be increasing the levels of the human placenta lactogen, and human placenta lactogen is directly responsible of the high levels of glucose in the blood during the third trimester. With respect of adiponectin, there is an inverse association between maternal serum adiponectin levels and the fetal growth. So it's going to be low levels, and because we have high levels of glucose, blood glucose levels, high levels of human placenta lactogen, and insulin resistance, woman during the third semester is going to be seen with a high growth of the fetal, and this is known as macrosomia. So the placenta is the responsible for gestational diabetes. There is an insulin resistance due to the increased levels of human placental lactogen. After the placenta is out of the body of the woman, the insulin resistance dissipates. And usually we don't need to treat with diabetes medications after birth on those patients that has gestational diabetes, since those glucose levels will going to tend to the normal without any exogenous pharmacotherapy. But do we have risk factors for gestational diabetes, and can we prevent a person that had gestational diabetes to have diabetes? So the risk of recurrence of gestational diabetes is increased up to 60%. And those that have gestational diabetes, 50 to 60% will develop diabetes in the following 10 to 15 years. We need to recommend lifestyle modifications in order to delay or prevent developing diabetes on those patients. Those patients that have normal glucose levels should be reassessed every 3 years. And for those that with prediabetes should be assessed annually. Based on observational studies, breastfeeding may prevent the development of diabetes type 2 in mothers with a history of gestational diabetes. So we can recommend that. So the key action in order to prevent diabetes in women who have gestational diabetes is to reassess glucose levels. So what are the consequences of gestational diabetes? Well, we need to avoid the high levels of hyperglycemia. That's the important thing. So consequences of hyperglycemia during pregnancy is going to be polyhydramnios. It is not well known why this occurs, but it seems that hyperglycemia in the fetus makes the fetus produce more amount of urine, and that will increase the amount of amniotic liquid in the consequence of producing polyhydramnios. Preeclampsia is one of the consequences of gestational diabetes, and also fetal macrosomia, and also after birth neonatal hypoglycemia. There is a lot more consequences, but I did not post. I only post here the most important ones. With respect of multiple gestation, there are several complications after. The most important complication is going to be the preterm birth when we have a multiple gestation. Of course, preterm birth will increase perinatal mortality, neonatal morbidity, or any long-term morbidity of twins. There is going to be a higher risk of fetal growth restriction and congenital anomalies. It is important to know that monochorionic twins can have intravascular anastomosis in the placenta and can have an unequal placenta sharing, and that will give additional risk or serious complication. We can also have what we call twin-to-twin transfusion syndrome or twin anemia polycythemia sequence. And of course, selective fetal growth restriction of one or both of the twins. We can also, in monoamniotic, which shares the amniotic sac, also there are risks for sequelae of cord entanglement. To explain a little bit about when we have a twin gestation, remember we have a chorionic sac, we have a placenta, and we have an amniotic sac. We have a chorionic structure, a placenta, and amniotic sac. So in the case of dechorionic and deamniotic twins, means that they're not sharing the chorionic structures. They're not sharing the placenta. They have each one has their umbilical cord, and each of the products have their own amniotic sac. This dichorionic and diamniotic twin multiple gestation is the one that's going to have the least risk factors for complications. If we have a monochorionic, they are sharing the same placenta and the same chorionic structures, but they have two different amniotic sac, and each one of them have this blood supply from this different parts of the placenta with their own umbilical cord. This is called monochorionic but diamniotic twin or multiple gestation, okay? The one that I mentioned before is the one that is sharing monochorionic, and also monoamniotic is only having one amniotic sac and only one chorionic structures. Though this is the one that's going to have the most important consequences of monochorionic twin-to-twin transfusion syndrome, or anemia, or polycythemia, or sequelae with the cord, specifically if they also have problems in sharing blood perfusion. Also, the cojoint twins are also monochorionic and monoamniotics. The cleavage of the egg to form these different types of multiple gestations will occur a little bit later in order to have cojoint twins, which is not, it's rare, it's not common. What are the risk factors for a multiple gestation? Well, of course, the use of fertility enhancement treatment, maternal age, advanced maternal age. It seems like geographic area and race has to do, because there's 50 for multiple gestations for every 1,000 births in Africa versus only 8 per 1,000 births in the United States. The multiparity, family history of twins, maternal weight and height has to do. Obesity and tall individuals have greater risk of dizygotic twin birth than those that are underweight. Also, diet seems to be a factor affecting the dizygotic twinning rate in some geographical areas. Let's talk a little bit about classification. Hypertensive pregnancy disorders can be classified in 6 types. So a person that already had hypertension before getting pregnant, that's number 1. Number 2, development of gestational hypertension after the 20 weeks, or developing an atypical preeclampsia before 20 weeks. Preeclampsia, which occurs after 20 weeks. Eclampsia can occur after 20 weeks during labor. And HELP or hemolysis elevate liver enzymes and low platelet count, or what we call HELP syndrome. What are the high factors for developing preeclampsia? Well, I just bold here the ones that almost all the associations agree with. A history of preeclampsia or in a previous pregnancy, having chronic hypertension, pregestational type 1 or type 2 diabetes, having chronic kidney disease or autoimmune disease, which means usually having any previous medical condition of hypertension, diabetes, or kidney disease or autoimmune disease are all in agreement of high risk factors to develop preeclampsia. The other ones are not accepted by all the organizations. With respect of moderate risk factors for developing preeclampsia, we have nulliparity, first degree relative with preeclampsia, multi-gestation pregnancy, more than 10 years pregnancy interval, and age over 40. The other ones, some organizations indicate that it is important, others not. How do I summarize hypertensive pregnancy disorder? So let's talk a little bit about preeclampsia. We talked about this in the PowerPoint for day 0 and for day 1. So preeclampsia, what I want you to remember is it has to do with a defective spiral artery remodeling and also the connection with the extra trophoblast villus of the placenta or the newborn placenta will determine a placental hypoperfusion. That hyperperfusion is ischemic and reperfusion simultaneous action because of that defective connection between those two structures is going to progress in vasoconstriction and endothelial dysfunction. That will develop thrombosis in the endothelium, and also vasoconstriction will be responsible for hypertension, and the consequences of a hypertension will be proteinuria and or damage, specifically in target organs. So basically, preeclampsia is an endothelial dysfunction that will produce problems over the placenta with consequences for the fetus, over the cardiovascular system with consequences for the mother, and also it can progress into eclampsia with consequences over the encephalus. Hypertensive pregnancy disorder also can be HELP syndrome, which is an extension of the previous pathophysiology that I explained for preeclampsia. But we're going to be seeing hemolysis. It could be related to an uremic called hemolytic uremic syndrome. It is also an endothelial injury with fibrin deposit that also occurs in preeclampsia with thrombotic microangiopathy, and that it's going to develop an hemolytic anemia. It's called microangiopathic hemolytic anemia, or MAHA. Also progressive liver damage with elevated enzymes levels, and the plaquette activation with more thrombosis formation and consumption of the plaquettes, which will lead to a thrombocytopenia. And this syndrome has a very high mortality. It has to be early diagnosed and treated immediately with therapeutics that will prevent the progress, and also with blood transfusion and specific plaquettes infusions. Eclampsia, even though the pathophysiology is not well understood, it seems like the etiology is multifactorial. Apart from what we see in preeclampsia, we're going to see seizures, and seizures are going to be caused by cerebral edema, and a hypertensive encephalopathy can also play a role. We can prevent eclampsia by the infusion of magnesium sulfate in patients that have a high risk for any of the hypertensive pregnancy disorder. Now let's talk about gynecology. So this is just very generalized review. We talked a lot about premenopausal women, meaning less than 40 years usually. And we talked also about some of the disorders that are common in premenopausal women. So we differentiated like vulval carcinoma being the usual vulval intraneoplasia, which main etiology is the human papillomavirus to be common in premenopausal women. We also talked about sexual transmitted disease, very common in premenopausal women, and also breast cancer can be present in premenopausal women. Pregnancy disorders, because menopausal women cannot be pregnant. Pregnancy disorders of the first, second, and third trimester are part of the premenopausal woman disorders, as well as labor disorders first, second, and third stage. Also PCOS usually is diagnosed in the premenopausal woman. Postmenopausal woman disorders, we characterize differentiate vulval intraneoplasm characterized by keratinized lesion in pruritus as part of the etiology for vulval carcinoma. This one is not depending on the virus infection. Postmenopausal women are more prone to have mass pending in as pelvic organ prolapse. It could be a uterine prolapse, it could be a cystocellular, it could be a rectocellular prolapse. Abnormalities in the mammogram are more common seen in postmenopausal, and usually they progress. The ductal carcinoma in situ progress to breast cancer. Vaginitis and urinary infections are very common during the menopause or perimenopause period, and abnormality uterine bleeding can lead, usually if it's present, to in a postmenopausal woman, it will lead to an endometrial cancer. If an abnormal uterine bleeding occurs in a premenopausal, we can surely discard first benign etiologies and then discard the endometrial cancer because it's less common. If we can organize from the most common gynecology cancer in the US, we should start by saying that those cancers that occur in the uterus, specifically in the corpus of the uterus, are the most important cancer seen in the USA. Talking about gynecology cancer incidence, the second most important is still cervix cancer, even though we're doing the pap smear. In third place is ovary cancer, followed by vaginal cancer, and then fifth place, vulval cancer. If we talk about melanoma, which it is one important cancer that you have seen when you went over dermatology, melanoma in with respect of a gynecology cancer incidence, we're going to find it in first place in the vulva, second place in the vagina, in third place in the cervix. Now let's talk a little bit about histopathology information. We have been classified based on histopathology, tumor lesions or any lesion with growth, abnormal growth, as benign or malignant, right? But we can have also in between them, we talked about a lesion that can develop into a low grade or a high grade growth. And also, we're going to be seeing, especially during pap smear, pre-malignant lesions. The other thing that it's important in histopathology is to know the type of carcinoma. The type of carcinoma that develops depend on the type of tissue. So if it's an epithelium, usually those carcinoma are called squamous cell carcinoma. If it develops from glands, usually that is called adenocarcinoma. So adeno means glands. Okay, based on this little introduction, we can go over some of the main carcinoma in female, and we have that endometrial carcinoma. Most of the endometrial carcinoma based on frequency or incidence are 90% are low grade. Type 1 are going to be endometrial adenocarcinoma. The other type that is more frequent is the serous carcinoma. 75% of those are going to be high grade type 2, and we have different type of serous endometrial carcinoma, including clear cells, carcinosarcomas, undifferentiated, morphological high-grade serous that are greater than 50% of those serous carcinoma. With respect of the histopathology of the vulval cancer, we just mentioned that the most frequent one is squamous cell carcinoma. And there's two types of squamous cell carcinoma. One that's the usual VIN with low grade and high grade. This is HPV dependent and usually affects younger patients, and it's less likely to progress to squamous cell carcinoma. The one that's a DVIN, it's HPV independent, but typically it does progress to a keratinized squamous cell carcinoma. And it's also more frequent in older lead patients. With respect of cervical cancer, we have the main types are going to be the squamous cell carcinoma. It corresponds to 80% of cervical cancers, and they're going to be located outside. Okay, in the adenocarcinoma are going to correspond to the 15% of the cervical cancer, and we have a combination of adenosquamous carcinoma, only 3 to 5%. The one that are associated with human papillomavirus, and they are detected in 99.7% of the cervical cancer, usually are HPV 16 subtype and 18 subtype of HPV. Those are found in almost 70% of our cervical cancer. Now let's talk a little bit of the interpretation results of a pap smear, because it's important to understand this so I can go over the pathophysiology. So if I have a negative result, it means I don't have any intraepithelial lesion or any malignancy. There's no cellular evidence for neoplasia. It's a negative Papa Nicolau result. ASC means atypical squamous cells, means if I have an atypical squamous cell US, means that it is with undetermined significance. That means that some cells are normal, but some cells are not normal, or some cells are precancerous, okay? Precancerous cells can be associated with infection, irritation, or intercourse. So atypical squamous cells, undetermined significance is, you can write it down, or you're going to see it in the pap smell result as ASC-US. We can also see in ASC, a typical squamous cell, but high. What this one might be a sign that the patient can have a high grade. So then we have pre-malignant finding of an invasive squamous cell carcinoma. The pre-malignant signing are going to be low grade or high grade. So low grade is a low grade dysplasia. It was called before CIN1. High grade right now was what we called previously CIN2 or CIN3 or carcinoma in situ. Okay? And then we have the glandular. So all of these atypical squamous cell or squamous intraepithelial lesion of high grade or low grade are premalignant. Okay? Then we have the ones that has to do with glandular abnormalities. Atypical glandular cell, AGC. We are going to be seeing endometrial or cervical cell change that are abnormal and must be evaluated more closely. So AGC can favor a neoplasm, and it needs but it's not sufficient to a diagnosis of adenocarcinoma. AGC has to do with glands, and it will progress to adenocarcinoma. And AIS, it's a premalignant lesion for invasive adenocarcinoma. Okay, so now let's explain the histopathology of the cervix cancer. So when I have a typical, this is atypical squamous cells. I have an atypical squamous cells. The pre-malignancy lesion is going to be low grade or high grade of intraepithelial lesion, of squamous intraepithelial lesion, high grade or low grade. And those two, low grade progresses to high grades can progress to an invasive squamous cell carcinoma. If I have an atypical gland cell lesion, this one, a typical glandular cell, 50% of those can go to low grade or high grade. 30% of those AGC, by the way, are related with HPV. Only 0.5% are going to progress into adenocarcinoma. And only 1% of those are going to progress to a premalignant of invasive adenocarcinoma. Okay, so usually when we have glandular, atypical glandular cells, they can progress into low grade or high grade of a squamous cell abnormalities and progress into an invasive squamous cell carcinoma, or they can progress only 1% into a premalignancy of invasive adenocarcinoma, and of those premalignancy, only 0.5% will progress to adenocarcinoma. By the way, that is, what is this meaning to you? That the most common cervical cancer is going to be a squamous cell carcinoma. So that's why if we are diagnosing by pap smear, we are going to be getting the results of a typical cells of indeterminate significance, or we can get a low-grade squamous intraepithelial lesion, or a high-grade squamous intraepithelial lesion, or a squamous cell carcinoma. Squamous cell carcinoma, it also has the same lesion of the high-grade squamous intraepithelial, but it has larger nucleoli. It has necrotic debris in the background, and it has other abnormality in the cytoplasma that the histology will report to you as a squamous cell carcinoma. What are the risk factors for cervical cancer? Well, we have cervical cancers that are related to HPV and those that are not related to viral infection. Those related with HPV, we have early onset of sexual activity, multiple partners, multiparity at early age at the first birth, history of vulvar or vaginal squamous intraepithelial neoplasia or cancer, of course, immunosuppression, HIV infection, co-infection with chlamydia trachomatis is HPV related, also risk factor for cervical cancer, and also with herpes simplex virus. Remember that HPV subtypes that are going to be causing 70% of the cervical HPV related worldwide cancer is going to be subtype 16 and 18. Not related to HPV, there are other risk factors like low socioeconomic status, race, ethnicity, African American, use of oral contraceptives, smoking, family history. There is a negative risk factor, which is protective. It seems like that females that their partners are circumcised, male partners, they have a very low risk of developing cervical risk factors. Usually Jewish partners, spouses, have very low risk of cervical cancer. Let's talk a little bit of breast cancer. We know that we have different breast cancer. Those that come from the ducts are called ductal carcinoma. Those that develops from the lobules are called lobular carcinoma. So we have an invasive ductal carcinoma or an invasive lobular carcinoma. The most important based on histopathology cancer for the breast is going to be the ductal carcinoma in situ. This is the most diagnosed in the United States, and it's the one that we can diagnose with mammogram in early stage. Remember, if it's a ductal carcinoma in situ, means that it stays inside the myoepithelial cell layer. It does not invade. But we have three grades: low grade, intermediate grade, and high grade for ductal carcinoma in situ. After the ductal carcinoma in situ has a great potential to transform into an invasive breast cancer. The TNM stage, the first site that the ductal carcinoma invades, it's going to be the axillary lymph nodes. So these lymph nodes has to be evaluated in all patients with suspicion of an invasive cancer to determine the end stage, which means the number of lymph nodes that are positive. This will relate directly with prognostic and predictive factors for those patients that are negative. The 60% will have an overall 5-year survival. Those that are positive, only 30% will have a 5-year survival. Also, we talked about estrogen receptors being positive or progesterone receptors being positive. Those are hormonal receptors. If they are positive, they are related with better prognosis because we can treat with anti-estrogen treatment. Also, the presence of HER receptor 2, which is a growth factor, is also a prognosis that we can evaluate, because those patients that are positive for that receptors can be treated with immunological treatments, or antibody therapy, target responded therapy, trastuzumab. Remember that other lesions for breast, they have different cancer risks based on the increase of risk for development carcinoma, even the ones that are considered benign lesions like proliferative fibrocystic change or the papilloma that are benign disorders have up to twofold increase in cancer risk. Of course, a typical ductal hyperplasia has 4 risks to develop carcinoma. And of course, the one that has 8-fold cancer risk is going to be the ductal carcinoma in situ. With respect of uterine disorders, we have an abnormal uterine bleeding, can be caused by high levels of estrogens that will produce hyperplasia or increment of the growth of muscles or endometrium, producing leiomyomas and polyps. We can have an abnormal uterine bleeding also when the patient has endometriosis or when the patient has endometrial cancer. There is other causes of abnormal endometrial bleeding. We would like you to use the new terminology as infrequent uterine bleeding or frequent uterine bleeding or abnormal uterine bleeding combined with heavy menstrual bleeding or abnormal uterine bleeding combined with intramenstrual bleeding, amenorrhea, or the use of specific in the use of the specific terminology for any of the specific situations. So abnormal uterine bleeding etiology can have a benign background. It could be as non-serious, like as just unknown ovulation cycle or endometriosis or a pregnancy, which is the most common cause of benign uterine bleeding. Intermediate etiologies are endometrial hyperplasia, but malignancy has to do with metaplasia, adenocarcinoma of the endometrium, stromal neoplasia of the endometrial, or myometrial neoplasia. This is some of the exercise of the matching, but please relate to this mnemotechnic that is very useful in order to review the etiology for abnormal uterine bleeding. Leiomyoma pathophysiology, since they have receptors for progesterone and estrogens, pathophysiology is based on the effects of the estrogens over the myomas, and that will promote the growth of the muscle cells. And usually after menopause, with the absence of estrogens, we're going to see that those leiomyomas reduce their size. Endometriosis has 2 hypotheses, the metastatic one in the retrograde menstruation or Samson theory, who explains the origin and pathogenesis of endometriosis. Endometrial carcinoma differentiates itself for endometrial hyperplasia because of the capacity of invasion and metastasis in distant size, even though both of them, they can have hyperplasia of the tissue or, okay, we already talked about this. No. Okay, with related of breast cancer, some of the other important pathophysiology has to do with genetic mutations. We inherit DNA defects, specifically BRCA1 and BRCA2. Those family history of ovarian and or breast cancer will increase breast cancer development, and also those individuals with the immune system attack cells that will develop abnormal DNA or abnormal growth. If the immune system is not able to detain the abnormal proliferation, breast cancers will develop. So, let me go here. Sexual transmitted diseases, pathophysiology. It is important to analyze that sexual transmitted diseases are those diseases that are transmitted from an infected person to a susceptible person. They can be divided as bacterial, viral, or parasites. Etiologies, when during the intercourse there is an exchange of the body fluids from the infected partner to the susceptible one. If the susceptible partner has microscopic aberrations within the mucosal of the penis, vagina, or anus, or any other, there is a higher possibility of infection. Of course, the use of not use of condom will also increase the risk of getting sexual transmitted disease, but not all of them, by the way, because remember that sexual transmitted disease also transmission can include intravenous drugs, and not only intercourse, can also the transmission be done during vaginal birth, childbirth, or breastfeeding. Like for example, HIV, as a sexual transmitted disease, can be transmitted by all those transmission pathways. There is something that's essential, the essential sexual transmitted screening based on pathophysiology. Where do I'm going to get the genital sample or any additional test? I did this table. It was modified from one of the other table. I include some other things here. So if I have an asymptomatic patient suspecting it has a sexual transmitted disease, I'm going to go over the simplified STI testing based on the pathophysiology and the recognition of what are the most common sexual transmitted disease. I will do a blood test for HIV and syphilis, and I will do a vulval-vaginal swab just to discard chlamydia and gonorrhea. Patient is completely asymptomatic. If I have warts, I need to discard human papillomavirus. I need to do exactly the minimum test as HIV and syphilis, and I need to do the minimum test of chlamydia and gonorrhea if I have warts. Okay, and the warts testing has to be a specific test for viral hybrid capture HC2 test. Okay, sometimes if you have warts, also test for subtypes, because subtype 16 and 18 can be a risk factor for cervical carcinoma. Okay. Vaginal symptoms. If the patient has vaginal discharge, it is important, apart from the basic, to include a swab for microscopic or testing or culture in order to discard candidas and bacterial vaginosis. Also, we do a very simple smear or wet mount or culture with or a nucleic acid amplification test, but sometimes even only with a wet mount, we can, under the microscope, determine Trichomonas vaginalis. So when I have vaginal symptoms, it's a little bit further. I am including, apart from syphilis, HIV, chlamydia, and gonorrhea, I'm including candidas, bacterial vaginosis, and Trichomonas vaginalis. So this is like the second box. When I have a genital ulceration, you need to think about viruses. Herpes virus, do a swab for virus. Okay, if you have genital ulceration, we do the basic. We can also do trichomonas, but we do a swab for virus, specifically herpes simplex. If I have an abnormal bleeding uterine device or intrauterine device infection in that patient, and I'm suspecting also STD, because of the epidemiology of multiple partners, I will do the basic for HIV, of course, and syphilis, chlamydia, and gonorrhea. I will do the swabs for candida and bacterial vaginosis. I will do trichomona. Of course, this is an abnormal bleeding. I need to discard other things. And also, I will do aerobic for aerobic vaginitis, deep endocervical swab culture, and for anaerobics. So I want to discard aerobics and anaerobics here, including Staphylococcus aureus and Streptococcus B group bacteria, which are responsible for high inflammatory symptoms. And that will produce an abnormal bleeding. If I have a high-risk scenarios, the patient is an intravenous drug user, sex worker, swinger, woman from high prevalence area, or a lot of contact partner, or some of same or bisexual men, or contact with men-to-men sex. I will do the basic. I will do the next second block, basic second block, and of course I'm going to include blood tests for hepatitis B and hepatitis C. So this means, depending on the symptoms that I have, I will suspect if I have warts, I will suspect the etiology can be human papillomavirus. If I have vaginal symptoms, I can suspect that I can have, apart from the basic, I can have bacterial vaginosis or trichomoniasis. I need to discard also chlamydia and gonorrhea. If I have genital ulceration, I need to discard a viral infection for herpes simplex, even though I'm doing also trichomonas this screening. If I have an abnormal bleeding because the patient is pregnant and I need to discard an STD, I need to go a little bit further, the basic, but also include discard of group B Streptococcus or Staphylococcus aureus. I will need to do a deep endocervical swab culture. If I have a high risk scenario, I need to discard the previously, but specifically blood test for hepatitis B. For torch pathophysiology, which means vertical transmission of infections during pregnancy, there is a parasite called Toxoplasma gondii, which transmission occurs through oocytes that go through the placenta. So we have congenital transmission, but depending on the trimester of the infection, we will have different manifestations. So if the woman gets acute infection with Toxoplasma gondii, the earlier the infection is, even though there is less probability to have the infection, there is more probability to be severely ill with congenital malformation. Okay? Because of the size of the placenta, there is less chance of those oocytes to pass through the placenta. But once the infection is done in the early trimester, the possibility of congenital malformation is high. Mostly, infections occur during the third trimester, but the possibility of congenital malformation is less. With respect to syphilis, it's transmitted through the placenta, and 80% of the infections also occur in when the patient is recently infected. Also, acute infections of the mother when they're during labor can also be a part of the transmission. Rubella is transmitted to the mother by aerosols, but it's transmitted also through the placenta to the fetus, with consequences, of course. There is a rubella syndrome.